Discuss the etiology, clinical features, investigations, and management of gout. Gout refers to disease that occurs in response to the presence of monosodium urate crystals in joints, bones, and soft tissues. Etiology. It occurs due to hyperuricemia, that is, normal value less than 7 milligram should be there, but increase in this value is called as a hyperuricemia. Causes of hyperuricemia are as follows. There are mainly three causes, that is increased intake, increased production, decreased renal excretion, most common cause of hyperuricemia. Increased intake. Intake of purine rich foods, that is, for example, liver, kidney, meat, mushrooms. Beer is particularly rich in guanosine, a purine nucleoside. Increased production. Hypoxanthine guanine phosphoribosyl transferase, that is HGPRT deficiency. Phosphoribosyl pyrophosphate, that is PRPP synthetase overactivity. Glucose 6 phosphatase deficiency, that is glycogen storage disease type 1. Increased nucleoprotein turnover in hematologic conditions such as lymphoma, leukemia, hemolytic anemia. Increased rates of cellular proliferation and cell death is seen in psoriasis, cancer, chemotherapy, radiation therapy, malignancy. Obesity. Decreased renal excretion, which is the most common cause of hyperuricemia, include inherited isolated renal tubular defect, that is under excretors, renal failure, lead poisoning, diabetic ketoacidosis, lactic acidosis, hypothyroidism, drugs such as thiazide, pyrazinamide, cyclosporine. Epidemiology. Gout is more common in males. Male is to female ratio is more than 10 is to 1. Prevalence increases with age and increasing serum uric acid concentration. Clinical features. Three types of clinical presentation can be recognized in the natural history of gout: acute gouty arthritis, recurrent and chronic gout, chronic Tophasius gout. Acute gout. The typical attack of acute gouty arthritis includes the following clinical features. Usually involves single distal joint. Most commonly involved joint is base of great toe, first metatarsophalangeal joint known as podagra, or the knee. Other common sites in order of decreasing frequency are the ankle, midfoot, knee, small joints of hands, wrist, and elbow. Spine and large proximal joints are rarely involved and never as the first site. Onset of arthritis is sudden, and there is severe pain, redness, swelling of the affected joints. Complete resolution occurs within a few days to several weeks. There may be periarticular swelling and erythema accompanying fever, malaise, and even confusion, especially if a large joint such as the knee is involved. As the attack subsides, pruritus and desquamation of overlying skin are common. Acute attacks may also manifest as bursitis, tenosynovitis, or cellulitis. Recurrent and chronic gout. After an acute attack, some people never have a second episode. However, some may have second attack usually within 1 year, and the frequency of the attacks gradually increases with time, leading to joint damage and chronic pain. Chronic Tophasius gout. Tophasius gout is characterized by collections of solid urate in connective tissue which may be calcified. These collections produce irregular firm nodules, that is tophi, at the usual sites for nodules around extensor surfaces of fingers, hands, forearms, elbows, Achilles tendons, and sometimes the helix of the ear. They may be clinically visible or detected by imaging. Tophi are usually painless and non-tender. Large tophi may ulcerate, discharging white gritty material. Renal and urinary tract manifestations. Uric acid stones may form and cause renal colic. Urate crystal deposition in the interstitium of the medulla and pyramids leads to chronic inflammation, fibrosis, glomerulosclerosis, and secondary pyelonephritis. Investigations. Polarizing microscopy. Definitive diagnosis requires identification of monosodium urate crystals in the aspirate from a joint, bursa, or tophus. Histologic examination. Birefringent urate crystals may be visible in biopsy specimens. Uric acid levels in the blood, these are elevated, that is more than 7 mg per deciliter. However, occasionally it can be normal, that is less than 7 mg per deciliter. 24-hour urinary uric acid excretion. This can identify uric acid overproducers. Urea, creatinine should be measured to rule out renal dysfunction. Complete blood picture, ESR, and peripheral blood smear should be done to rule out any myeloproliferative disorders. X-rays. These can assess the degree of joint damage. In early disease, they are usually normal, but in advanced disease, narrowing of joint space, sclerosis, cysts, and osteophytes, changes of OA may develop. Calcified tophi may be visible on X-rays. Management. In acute attack, oral NSAIDs, example naproxen, diclofenac, indomethacin, can give effective pain relief and is the standard treatment. Oral colchicine is effective in acute attacks but can cause vomiting and diarrhea as side effects. Steroids, either oral or intra-articular, can give rapid relief, can be used if symptoms are very severe. Aspiration of the joint gives instant relief, and when combined with an intra-articular corticosteroids injection, effectively aborts the attack. Note that allopurinol and uricosuric drugs should not be given during acute attack because they can worsen the symptoms, that is, they can worsen the attack. Long-term management. Lifestyle changes. Correct obesity and reduce alcohol consumption. Avoid high purine diet, that is seafood, red meat, and offal. Stop diuretics if possible. Hyperuricemic drugs. Allopurinol inhibits xanthine oxidase and reduces conversion of hypoxanthine and xanthine to uric acid. Dosage is 100 to 300 mg per day daily. The sharp reduction in tissue uric acid levels after allopurinol therapy can dissolve monosodium urate crystals and trigger acute attacks. This risk can be minimized by starting at low dose, that is 100 mg. Since it can exacerbate acute attacks, it should be withheld till the acute attack subsides. Febuxostat is a new drug and is non-purine selective inhibitor of xanthine oxidase. Febuxostat is given orally and is metabolized mainly in the liver. In contrast, allopurinol and its metabolites are excreted primarily by the kidney. Therefore, febuxostat can be used in patients with renal impairment with no dosage adjustment. The goal of treatment is to reduce serum uric acid level to lower half of normal range. In most cases, allopurinol will need to be continued indefinitely. Uricosuric drugs such as probenecid or sulfenpyrazone also have equal efficacy to allopurinol but require more frequent dosing. Uricosurics are contraindicated in overproducers. They already have gross uricosuric. Those with renal impairment ineffective, and in patients with urolithiasis, that is increased stone formation. Pegloticase is a pegylated form of recombinant uricase, an enzyme that converts urate to allantoin, which is more soluble. Pegloticase is used in patients with gout in whom the other treatments have been unsuccessful in lowering the serum urate level. Asymptomatic hyperuricemia need not be treated unless the levels are very high, that is more than 10 milligram per day per deciliter, or there is strong family history of gout or urolithiasis.